So good afternoon, everyone. My name is Tuli Racer, and I am the project manager of the IAS Corporate Partnership Program. And it is my great pleasure to open this Industry Towards an HIV Cure Collaboration Group Roundtable on monitoring HIV viral load during cure interventions with ARV treatment interruption. As a reminder, there's a couple of housekeeping rules for the roundtable. So this roundtable will be recorded, and the recording will be made available to the participants and on the IAS website as part of the educational materials in the coming weeks. So by staying in this meeting, you consent to being recorded during the roundtable. We encourage you to send questions to our presenters at any time through the chat function at the bottom of your screen and during the guided discussion by raising your hand using the button at the bottom of the screen. And please do remember to focus your questions on today's roundtable topic. I would now like to hand over to the Towards an HIV Cure Industry Collaboration Group co-chair, Bonnie Howell, for a brief introduction of today's roundtable. Over to you, Bonnie.
Okay, thank you, Tuli. Good morning, good afternoon. My name is Bonnie Howell. I am Associate Vice President of Pharmacology and the Global HIV Cure Lead at Merck & Co. in the USA. So this roundtable today will bring together industry representatives from the Industry Collaboration Group and beyond, researchers and clinicians to explore how to best perform point-of-care viral load testing and cure research involving analytical treatment interruptions in low and middle income countries. In many low and middle income countries, HIV viral load testing occurs at centralized laboratories, and a time to result delivery is lengthy. It also prevents timely monitoring of viral load while subjects are receiving a cure intervention, and thus providing timely viral load results to people living with HIV while in a cure study remains a challenge. So I'd like to welcome all the participants and our guest presenters. We're going to have 4 short presentations today, followed by a guided discussion led by Sarah Fiedler, Thumbi Ndungiyu, and myself. And please note that all the detailed biographies can be found through the link that's going to be posted for you in the chat by our IAS colleagues very shortly. So we have a full agenda today, and we ask that all the speakers try to not go over their allocated time slots to allow time for discussion. And again, we encourage you to ask your questions in the chat, and we'll also try to have the speakers respond to them either after the presentations in the chat, or we'll pull them into the panel discussion. Okay, so with that, I think I'm going to hand it over to Tim Henrich, who also co-leads this Industry Collaborative Cure Group, and he's going to sort of set the stage here for the challenges of viral load monitoring in an ATI setting. Over to you, Tim.
Thank you, Bonnie. I'm Tim Henrich from University of California, San Francisco. Welcome to, I think this is actually an extremely important roundtable discussion. I should mention that there have been, several forums to look at treatment interruptions in the last several years, especially with the advancement of the HIV cure strategies, agenda, therapeutic vaccination, et cetera. And I think that this is an extremely important opportunity for us to really discuss how to address a lot of the technical as well as logistical and ethical challenges that involve ATIs, especially when we think about expanding into middle and lower income or resource challenged areas in this setting. So I just want to start off by saying, and I won't take too much time before we go into our speakers in the panel, is that treatment interruptions are clearly something that are becoming more and more common, and something that will be almost necessary in order to evaluate many of the strategies that we have been implementing over the past several years. For example, there really is no real way to know if a curative or eradication strategy in terms of reservoir reduction is going to work unless we do the natural history experiment. Obviously, we're looking for biomarkers, we're looking for better ways of predicting outcomes in the setting of such interventions. And these also include therapeutic vaccination, gene therapy trials, you name it, the whole gamut. And we really just don't have a good way of knowing or predicting how these are going to respond in the setting of removing ART or pausing ART for each of these interventions. There are many challenges. There are logistical challenges in terms of, as Bonnie had just mentioned, how do we do or roll out rapid viral load testing in areas where there may not be access or direct access to central laboratories or phlebotomy centers, or areas where people can get blood drawn on a routine basis. I think that is generally understood that we need to do, excuse me, fairly often and aggressive, intensive monitoring of viral loads during ATIs to keep them safe, as well as to obtain the endpoints that we need in this. Having designed and carried out several ATI studies, these are extremely challenging, even here in the US and California, where we have fairly dramatic access to these types of technology. For example, this is not just an issue of safety for the participant themselves, but also potential safety for participants' partners and also their lifestyle. I think we heard at the recent DARE symposium about individuals who have undergone very long ATIs. You know, we're talking months to over a year in the setting of not knowing if, quote, they may be having a viral load tomorrow, the next day, the following week. And this is a dramatic change in lifestyle for participants in the studies as well. It can be not just physically potentially dangerous, but also in terms of a person's well-being, their activities of daily life, et cetera. So I think this is an incredibly important issue to take up. We know from the intensity monitoring studies that we have run that these are resource intensive and they take an enormous amount of effort on the participants that we basically put on their shoulders to undergo during these studies. And I think a lot of things that as researchers we don't understand is the psychological toll that people undergo during these treatment interruptions. And I think so, you know, following up on that, we really need to have better technologies to look at either point of care, home testing, frequent testing that can be done either in privacy or without needing to travel to long centers, and even potential turnaround wait times, where even here in San Francisco during our ATI studies, it can take 3 to 4 days, depending on the clinical lab, to get a viral load test back. And I think this is, these are some of the logistical challenges that we need to address, and I know that we will have a wonderful discussion today doing so. And I wanted to just to kind of close out these initial thoughts with the fact that this is actually already being done. Kind of PCR monitoring or nucleic acid amplification in a point of care setting. Granted, not in the setting of HIV clinical studies, but for example, during the pandemic, certain large industries were providing home nucleic acid testing, TMA technologies for COVID, rapid COVID testing for return to work. And this had been done fairly extensive here in Silicon Valley, where people would test themselves and their families multiple times a week at home with technologies that were provided by those firms. And so obviously this is a cost-intensive resource, but this is currently being done not in the research setting, but in the real world situation in areas where there's a high, kind of a low barrier to resources to implement these types of studies. And so with those thoughts, I will now pass it over to Dr. Sinead Delaney Morletley, the Director of Research at the WITS RHI, South Africa, who will present lessons for monitoring viral load during PrEP with long-acting antiretroviral files. So with that, I will pass this over.
Thanks very much, Tim, and thanks very much to the IAS for inviting me to speak with you. I am not going to talk about cure or treatment. I'm actually going to share lessons from PrEP, but I think some of these lessons are still instructive. So next slide. And what I hope to share with you in the next 10 minutes is really what we have started to learn about screening or monitoring for HIV in the context of long-acting antiretroviral therapy. And our experiences come essentially from 2 trials, the HPTN 083 trial, which enrolled just over 4,500 participants who were cisgender men or transgender women who have sex with men in 43 sites. and the HPTN 084 trial, which involved women, just over 3,000 participants in 20 sites in sub-Saharan Africa. And these trials were evaluating the safety and effectiveness of long-acting injectable CAB for PrEP. And the trials were stopped early in 2020 for benefit. And since then, have continued follow-up of participants and have now begun offering injectable cabotegravir as part of an open label extension. But as a result of the data from these two trials, the FDA approved cabotegravir for PrEP, and we're starting to see regulatory approvals in several other countries and expect more in the coming months and years ahead. Next slide. So I think the first thing to kind of highlight is that HIV infection on long-acting injectable PrEP is a rare event. Across the two trials involving just under 8,000 person years, we've seen a total of 31 infections, and many of these infections are actually not infections on product. And I think it's important to kind of make the point that these events are rare because they may influence your test performance characteristics. Next slide, please. So what was the testing approach that we used in the trials? Essentially, there was testing done at sites. We used an HIV RNA test up to 14 days before enrollment. And then at every visit, participants were tested with 1 or 2 rapid tests, as well as an instrumented antigen antibody test. And if there were reactive results on any of those tests, there was additional testing, including RNA testing, and in some instances, DNA testing to resolve essentially discrepant test results. In addition to that, the laboratory center also did a range of testing of all samples on seroconverters using the Aptamer qualitative RNA test, as well as repeating an antigen antibody test and using discriminatory tests. And in some instances, we needed to use single copy RNA testing to determine timing of HIV infection. Next slide. So I think through the process of testing these infections, we've learned something about the sort of virology of HIV in the context of long-acting PrEP. And what we've learned is that cabotegravir is a very potent antiviral. It suppresses viral replication, and this leads to delays in antibody production. And so we've seen atypical test results. One of the concerns has been that because there are delays in diagnosis of HIV, that participants may experience prolonged monotherapy with cabotegravir, and that this may lead to instances of INSTI resistance. And in fact, there are a number of cases that I will talk about. I think what's important from a programmatic perspective is that resistance can be overcome with other non-INSTI regimens, but obviously it's a concern as we move forward into scaled up PrEP, particularly in areas that use dolutegravir-based first-line regimens. And so one of the questions was, well, would a sensitive HIV RNA assay actually help with detecting infections early? And just to kind of illustrate the point, if you look at the diagram, essentially this is follow-up time on the x-axis and CAB concentrations on the y-axis. And if you look at the blue line, that is when the site first detected the HIV infection in the participant. You can see from the green line that they had already received 1 injection, but actually at the laboratory center testing, when they did comprehensive testing, they back tested all the way through to screening and identified, in fact, that this person had been HIV positive at enrollment. And what you can also see across the top is that after injections, actually, there emerged INSTI resistance. So the idea is if we could add HIV RNA testing, could this potentially assist with earlier detection of HIV and potentially avoid the emergence of resistance? Next slide. So I think in part in response to these early findings, the FDA has actually required that cabotegravir be offered in the context of HIV screening, which includes tests approved or cleared by the FDA for diagnosis of acute primary infection. So essentially has required RNA-based testing. And while that may be feasible in some high-income country settings, it really is not going to be feasible in low and middle-income country settings. So this is where we get to thinking about what are the alternatives for point-of-care viral load diagnostics. Next slide. So in terms of we asked this question retrospectively using samples from HPTN 083, which had identified more HIV infections and had also identified these cases of INSTI resistance. Using those samples, could we evaluate the timing or the emergence of INSTI resistance and also assess whether adding a sensitive RNA assay might help? So these were the two assays that were used, including a low viral load INSTI genotyping assay, which had a threshold of detection below 500 copies per mil. Next slide. And here is a case study to kind of re-illustrate these points, again, sort of orientating you to the same as the previous graph. You can see the blue line is where the site detected infection, and the green lines are the number of injections that were received. The red line is the point at first positive test. And what you can see is that with viral load testing, at the first positive test, the viral load was 860 copies. And at sort of subsequent testing, they identified wild type virus. But over time, without sort of removal of or stopping of cabotegravir or the addition of antiretroviral therapy, you see the emergence of resistance-associated mutations in this case. I think the other thing to point out is you can see across the bottom line, so you can see the viral load 860, then not detectable, then less than 40, then 112. So this has been another feature of these emergent infections, is that we see very low viral loads because of the very suppressive effects of cabotegravir. And this is obviously important for thinking about the diagnostic resolution of future tests. Next slide. So in most of the cases that were evaluated, major INSTI resistance were first detected in samples with low viral load, not just those with high viral load breakthroughs. So that was one of our hypotheses. Perhaps we were just seeing very high viral loads with resistant virus, but in fact, resistant virus is detected even at very low viral loads and less than 250 copies per mil in the majority of cases, and as much as less than 40 copies per mil in sort of 2 out of 7 of the cases. These resistance mutations are observed close to the time of the first positive visit and when CAB concentrations are high. Next slide. So as a result of these findings in the open label extensions that I mentioned earlier, HIV RNA testing has now been included at each visit at which cabotegravir is administered. And although we don't have the results immediately, the idea is that it would prevent you administering the next injection, and so and potentially linking people to care more rapidly, and so avoiding resistance. Next slide. So the question then arose, well, is this what we're thinking about for programs? Because truly this wouldn't be scalable in many LMICs where the demand for prevention is going to be incredibly high. And when we look at the point of care HIV viral load assays that are available, and also those that are WHO pre-qualified, one of the real challenges is that the analytic sensitivity is really not in the range that you need for monitoring breakthrough HIV infection in long-acting PrEP. The point being that we see these very low viral loads and really need sort of resolution at the level of 40 copies per mil or less. Next slide. So I think the other sort of point that I wanted to make is that, kind of we're actually talking not about sort of disease monitoring, but screening for HIV. And we know early on in the HIV epidemic, there were real concerns about the use of RNA screening for diagnosis of HIV. And even in infant diagnostics, we have seen that there is a real challenge with the interpretation of low viral loads. And in part, kind of we need to recognize that this is because of the low test pre-test probability of infection. So because these are rare events, we're really stuck with trying to interpret, is this a true early infection that we're observing, or is this a real infection but with a low viral load? And it's been helpful to reflect on what's been learned from the prevention of mother-to-child transmission setting. So, for example, in South Africa, 16% of the non-negative tests were indeterminate, and about 3/4 of them were negative on repeat testing. So there is a phenomenon of false positive when you're doing large numbers of tests in a population that has a low probability of infection. And the reasons potentially for this are, as I mentioned, the low positive predictive value due to low prevalence, but also samples that are at or near the limit of detection because of exposure to antiretrovirals. So I think what we're learning from PrEP is that really we need more data, and hopefully we'll get some of this from the open label extensions that are ongoing. Next slide. So really, just to conclude that HIV infection in the context of long-acting PrEP is rare, and it's associated with atypical presentation of infection. This is because of the prolonged viral suppression that's associated with low viral loads and therefore low antibody production. What's intriguing is that this population, in fact, may be an important population for cure research because of the sort of suggestion that they have small reservoirs of infection. Importantly, HIV infection on long-acting PrEP is associated with diagnostic delays when we use conventional diagnostics, and this has led to concerns about the emergence of INSTI resistance and the idea that HIV RNA screening may help us to identify infection earlier and mitigate this. But I think the role of HIV RNA screening in this context really needs further investigation because this is a diagnostic, not a treatment paradigm. And we're further limited, I think, in LMICs because the point of cares don't have the analytical sensitivity required to detect early infection. So we're really stuck with the same challenges that we have with viral load monitoring in low and middle income countries until we can get improved point of care tests. But also there may be additional limitations that are associated with the difficulty of interpreting results that have low viral loads. And hopefully we will generate more data sort of in these open label extensions. But I think just to say that in many low and middle income country settings at the moment, considering the introduction of injectable PrEP, actually there is a feeling that, kind of we cannot adopt RNA testing at this point and really will rely on antibody testing along with the kind of potential associated consequences. So I think that's my final slide, and just to acknowledge the people who have contributed significantly to this thinking and to the discussions around this topic. Thank you very much.
Well, thank you. That was fantastic, and I think really highlighted quite a few of the questions that we would like to discuss in our roundtable. So really fantastic kind of real world data. Again, we're going to hold questions until the roundtable discussion. And next, I would like to introduce Dr. Liddy Troutman, and who is Associate Professor of Vaccine and Gene Therapy at OHSU. And it looks like Liddy is actually on the call, though I know it said that there was a pre-recorded talk. So we will continue on to Dr. Troutman.
Good morning, and thank you for inviting me to participate in this roundtable. I'm going to talk to you about non-viral load measurement of our rebound during ATI. And I will do so as previously I was working at the US Military HIV Research Program, and I had the fortune to work with Dr. Jintanet Anandvaranish, who conducted several clinical trials of treatment interruption in the Thai cohort. So the RB254 cohort is an acute HIV infection cohort that Jintanat started in Thailand, and where people are treated early in acute infection and have a very low reservoir, and these are good candidates for treatment interruption studies. So she conducted 4 clinical trials with treatment interruption with different regimens, treatment in FIBIC1, a latency reversing agent, a therapeutic vaccine, and VRC01, monoclonal antibodies, for a total of 67 participants in those different ATI studies. And my role when I was at MHRP was to do the immunomonitoring of those trials, to try to define correlates of viral rebounds, and also try to define predictors of viral rebounds. Before going to the immunomonitoring data, I wanted to share the resumption criteria of those clinical trials. It was after 2 consecutive viral loads of 1,000 copies, and the viral load was evaluated and monitored every 3 days during the treatment interruption period. And so one thing Jintanat and the clinicians who conducted the studies realized is that there was a burden of the frequent monitoring visits, which was actually the major reason for declining participation in the ATI studies. And some participants actually prefer to restart treatments to reduce the number of visits. They also realized that a lot of people in these trials exhibited signs and symptoms during the treatment interruption, with some reported adverse events. This was data from around 40 people, and you can see that 21 of these people reported adverse events, with a median time of 17 days after treatment interruption, 6 days after viral detection. But interestingly, 38% of those people actually had a viral load undetectable at the time they reported those signs and symptoms. So we received PBMCs from those trials, and as you can see here, all the participants except one rebounded with no clinical meaningful delay of time to rebound. So with this limited range of time to rebound in the ATI studies, it was difficult to do predictors of delay to rebound. And the one post-treatment controllers in the placebo arm of this vaccine trial that you can see here on the right actually carried the protective allele HLB57, not excluding that it might be a natural controller. So we measured different immune parameters in these different trials, and we used the same panels for all these 4 trials to measure T cells, B cells, and innate cells. And the first thing we saw was a CD8 T cell activation that increased with viral load or after viral load. You can see first on the FIBIC 2 and 3 treated individuals here, they have high viral activation of CD8 T cells in acute infection prior to treatment initiation. And then this goes back to very low level after several years of ART and at baseline treatment interruption. But when viral rebound occurs, you can see a significant increase of CD8 T cell activation, which is reduced again after 3 weeks after ART reinitiation. Interestingly, in the FIBIC1 treated individual who have very low level of CD8 activation in acute infection because they are treated very early, this CD8 T cell activation is still very low at baseline and 1 week prior to viral rebound. But most individuals actually show increase in CD8 T cell activation at viral rebound of 1,000 copies. And the one who don't actually show an increase 2 weeks after ART reinitiation. And in those individuals, we also followed tetramers, as you can see here in the colored line. And so when there is viral rebound in those individuals showed in black, you can see that there is an increase of those HIV-specific T cell responses in these individuals concomitant with the viral rebound. The difference between those 2 participants that I wanted to highlight is that in this participant, the time to rebound was 40 days, which led more time for the immune system to activate and respond at the time of our rebound. For this participant, the rebound occurred much faster, and the activated T cells were kind of delayed compared to the viral rebound, suggesting that a faster rebound is actually not letting the time for the immune system to get activated as fast. The CD8 activation was also confirmed by the team of Tim Henrich, who conducted an ATI study and showed that also post-HIV rebound, there was an increase in CD8 T cell activation, showed here, and also an increased expression of PD-1, the activation marker of CD8 T cells, but not prior to viral rebound. Team also looked at CD4 T cells and actually reported in a participant who had initiated treatment on PrEP and who had a long delay to rebound of ART, show that this participant exhibited an increased expression of CD30 on the CD4 T cells prior to viral detected and viral rebound. And this was confirmed in the ATI study with 20 participants, where you can see a significant increase of the expression of CD30 on CD4 T cells at the time of pre-HIV rebound, and this remains elevated during the rebound. Shelley Krebs at the MHRP looked at soluble markers in the plasma during the different ATI trials. These data are not published, and I'm showing here just the data from one of the clinical trials with N equals 8. But she was able to detect differences in soluble markers, and showing here that higher level of the TNF pathway member and soluble CD163, as well as soluble CD30, were actually 1 week after ATI associated with a faster rebound in the red lines. The soluble CD30 in the plasma was actually not validated by Tim Henry's cohort, where there was no elevation pre-HIV rebound, but only post-HIV rebound, suggesting that these data really need to be validated in different cohorts, in different places with different clades. The most interesting data we observed was the plasmacytoid dendritic cells. As you can see here, one example of one participant who showed a viral rebound in black, and you can see that the frequency of PDCs in the blood prior to viral rebound in blue was increased. And these are the concatenated data of the participant we measured in this ATI, showing that there is a significant increase between the baseline treatment interruption and the last aviremic time point before viral rebound in the frequency of those PDCs. And while those frequencies of PDCs are bleeping prior to viral rebound, they also exhibit increased activation markers with CD69, PD-L1, CD40, that are all significantly upregulated at the last aviremic time point prior to viral rebound. As these data suggested that the PDCs can sense HIV replication in tissues prior to detection of viral rebound in the blood. The last piece of data I wanted to share are also unpublished data, but showing that intervention can actually change the immune cell activation profile. On the left side is the latency reversing agent study, where the treatment of vorinostat, hydroxychloroquine, and Marviroc actually increased the innate and B cell activation pre-ATI. And this increase, as you can see here, with increased CD40 ligand on the PDCs, CXCR13 in the plasma, actually blunted the PDC activation after ATI. And on the right side, you can see the VRC01 study where the treatment during ATI decreased the fold increase of activation of CD8 T cells from baseline to peak viral rebound. As you can see, a significantly lower increase in the VRC01 treated compared to the placebo group, suggesting that intervention prior or during ATI can really change, and this needs to be kept in mind. And to summarize, I showed you that for non-viral measurement of viral rebound, some participants experienced signs and symptoms prior to or at viral rebound. The CD8 T cell activation is detectable at or after viral rebound, but not before. There is less immune activation at viral rebound when the rebound occurs fast, not letting enough time for the immune system to kick in. But most importantly, there is innate activation that can be detected 1 week prior to viral rebound detected in the blood, mostly PDC activation and frequency, CD30 expression of CD4 T cells, several soluble markers, and perhaps others if other parameters are measured in other studies. I also showed you that intervention at treatment interruption can affect the activation of immune cells, and more studies are needed to validate these immune markers of our rebound in blood and tissues in different cohorts. And I would say that there are some upcoming clinical trials looking at rebound in tissues and perhaps other markers. And these also need to be validated in other cohorts. This was mostly done in the Thai cohort infected with clade AE. And with that, I would like to thank Dr. Jintanadan Varnish, who conducted all these trials, the participants of these trials, my lab at MHRP and here at OSHU, all the collaborators and the funders. Thank you.
Okay, terrific. Lydia, thank you for that terrific presentation. And again, folks, if you have questions, please jot them down. We will come back to them at the end of the speaker presentations. So next, I would like to invite Chris Parkhouse, who is the Commercial Director of Southern and Eastern Africa at CPP, to present what's in the pipeline in terms of viral load of point-of-care assays. So Chris, over to you.
Okay, thank you, Bonnie, and thank you to the IAS for inviting me to this session. Next slide, please. Basically, CPP's mission is really delivering a better way to improve patient outcomes by enabling access to molecular diagnostic testing everywhere. Next slide, please. So I'm actually part of the Global Access Program, which is available to low and middle income countries. And really the goals of the program is to ensure equal access to care within a country. So basically, whether you live in the remotest part of the country or in the big cities within a country, you have the same access to testing capabilities, equally across all geographies. What we want to do is also help to strengthen integrated diagnostic infrastructure. And obviously, many of the low and middle income countries have undergone what's known as a diagnostic network optimization, looking really at the whole instrument base across the country in order to be able to provide services across the board, much closer to the patient. We really are trying to empower the healthcare workforce with our technology and helping to support the elimination of diseases. Obviously, when we look at HIV in particular, we really have to consider, a multitude of different diseases that could potentially impact these key populations. So we have to think about TB. There's obviously very high rates of TB infection along with HIV in Africa. We have to consider in certain key populations, such as people who inject drugs, hepatitis B and C. And we also have to think about, obviously, with HIV positive women, HPV infection as well. And along with all of that is obviously sexually transmitted infections as well, things like chlamydia and gonorrhea. So obviously what we're trying to do is to really enable a whole suite of tests to be available to HIV patients wherever they may be within a country. We go to the next slide, please. So we are present in over 100 countries. We have very strong presence, obviously, in low and middle income countries. And we have 7 either endorsed or WHO pre-qualified assays that can be utilized across the group. We go to the next slide. We really enable testing to be done all the way from centralized testing laboratories right down to rural centers. And as you can see, we have a range of different platforms that are applicable to the different levels within the regional and district parts of the hospital system, as well as rural and microscopy centers. And obviously, the full range of tests can be run on all of these instruments, with the exception of the Edge, which I'll talk about a bit later on, but that's the one to the bottom left where we're microscopy and rural centers. All of the other platforms are able to run the whole suite of tests. And so whether you run it in a central laboratory or you run it in a district or regional level laboratory, you're going to get the same level of performance of the test. You're going to get the same standard of test. And there's no difference in terms of the format of the test, whether it be centralized or very decentralized. The Edge system, which we will be launching in the first quarter of next year, which applies to the bottom left for smear microscopy and rural centers, will be a battery-operated device that will run the same cartridge and will run HIV viral load, HIV qual for EID testing, and MTB. The other tests will become available over time, but the initial suite will be those 3 assays. We move to the next slide, please. Obviously, many of you will be familiar with the fact that we can run the GeneXpert platform in many far-flung communities for critical diagnostics. So we have systems running on boats, in the back of mobile vans, and in storage containers across a whole gamut of countries. So it is very versatile in terms of where it can be used and the access that it can provide to different communities. We go to the next slide, please. There are a wealth of publications with respect to obviously near point of care testing using the GeneXpert. Some of the pivotal ones were obviously the CHI-led evaluation of point of care EID testing in 6 African countries, which was part of a bigger study along with ECPAT in total of 15 countries, that found that 72% of caregivers received infant test results on the same day as sample collection with the use of point of care testing, compared with only 1% with centralized testing. Furthermore, the HIV positive infants who received their test results on the same day were 6 times more likely to start treatment within the 90 days of the study than those diagnosed 1 or more days after sample collection. And that, along with the ECPAT study, was one of the pivotal publications that really led to increased adoption of EID testing and more decentralized EID testing across low and middle income countries. CHI also supported the rollout and evaluation of near point of care viral load testing across 57 public sector facilities in Cameroon, DRC, Kenya, Malawi, Senegal, Tanzania, and Zimbabwe from 2017 to 2019. In this large multi-country assessment, near point of care testing decreased the median time from sample collection to patient result return from 68 to 6 days compared to conventional devices in centralized laboratories. Time to clinical action for individuals with an elevated viral load also decreased to 3 days with near point of care testing compared to 49 days with centralized testing. And overall, 37% of the patients with elevated viral load test results on near patient devices had documented clinical action compared to only 7% of those tested via centralized labs. And again, that has led to some of the changes in terms of where point of care testing for viral load can be used in certain patient groups. A couple of others of interest are the DRAIN publication that looked at point of care viral load testing and same-day counseling with task shifting to an enrolled nurse compared to standard of care laboratory HIV viral load testing. And the results there showed the point of care HIV viral load testing with task shifting significantly improved viral suppression, retention and care, and referral into community-based care. If we go to the next slide, please. Some of the enhancement and innovations we're doing on the service delivery side is we're launching what's called Access Care 2 program. This is available in low and middle income countries, and basically service and support is combined into a single add-on price to the cartridge, which enables comprehensive service contracts and is fully inclusive of all of the service requirements that would be needed for that particular country. And we have that rolled out in about 10 countries at this time and are in discussions with a whole number of additional countries. We're also enabling super user training enablement, basically enabling key end users to empower them to achieve better usage of systems, upskilling and empowering local teams to help address staff turnover rates and training needs. And we're currently piloting that in Malawi at this time, and then we'll roll it out to the other countries within, obviously, the low and middle income area. We're expanding digitalization, adding new functionality to C360 to enable, obviously, results to be fed back to databases at the country level. And then we're also launching a series of partner and field service community activities that will enable customers' cases to be available on a visual dashboard for our service providers so that we can help close cases faster and also enable greater training on the ground to our authorized service providers. If we go to the next slide, please. In terms of the product pipeline, we have the dual target expert HIV viral load XC and HIV qual XC are currently CE marked, but are undergoing WHO PQ. I think many of you will be pleased to know that the HIV qual is now going to be GTC free. It actually won't require a heater block in order to remove the blood sample from the dried blood spot. The dried blood spot can be processed directly in the cartridge. So that will have major benefits for many countries. We also have a HCV viral load finger stick that is CE marked and currently undergoing WHO PQ, particularly useful in people who inject drugs where 20 to 30% of patients may not be able to, where you may not be able to get a blood draw. We're also going to be updating our MTB RIF assay to include INH, and the timeframes for that launch are listed on the slide. We also have an expert TB finger stick in development, which will enable differentiation between active and active TB. And then we have an express chlamydia gonorrhea test, which will be reduce the time to result down to under 30 minutes. And then, as I said, the Gene Expert Edge we'll have available in the first quarter of 2023. And that will be a battery-operated single-unit device that obviously can be used in the field with an 8-hour battery capability. Briefly to the next slide, just to give you the performance characteristics of the HIV qual XC and HIV viral load XC. And those are, as I say, currently CE marked and awaiting WHO PQ. Thank you very much.
Okay, terrific. Thank you, Chris. That was a great overview. So now we're going to hear from Elliot Raises from PEPFAR about the challenges with measuring viral load in low and middle income countries. So hand it over to you, Elliot.
Thank you, and it's a pleasure to be here. Thank you to the organizers for inviting me. As you can see, I am quite, as you will notice, I am quite enthusiastic about this this particular topic. But wanting to give a little bit of a perspective in terms of measuring viral load in low and middle income countries that PEPFAR at least has experienced. Next slide. So I'm going to just start with my key messages because this is sort of where I think we are right now. Scale up of viral load monitoring in PEPFAR supported countries has been a massive undertaking, as I'll try to briefly describe for you. That the results for action remain an ongoing challenge in our viral load monitoring program. And I do believe that, as I'll show you, that the potential impact of viral load point of care assays actually at this point in time in the history of PEPFAR remains uncertain. Next slide. So in terms of viral load scale up in PEPFAR, we've had an aggressive scale up, especially from 2015 to 2019. So basically by the time COVID hit, we had pretty much established our scale up, as you'll see. This includes both plasma and DBS specimen collection. This is an important consideration because as most of you know, the sensitivity for DBS in a centrally run laboratory remains much higher than the sensitivity for plasma. And although DBS is getting better, and those of you on the call who might be able to address how much better we can see from DBS. I would also say that PEPFAR is moving away from DBS at a lot of levels, so we've gotten much better at finding ways to transport plasma specimens to central labs or to hubs that can spin them down and then transport them to central labs. And so I do think that our proportion of DBS that we will be using over the next 3 or 4 years will probably be going down. The other PEPFAR data, so most of the data that I'm going to show you is PEPFAR data, and that relies on facility reporting. And that's an important distinction because lab data systems typically will show more viral load testing being done than is being reported at the facility level. And I think that's an important proxy for the data use. So in other words, if a viral load result never makes it to the individual patient chart, then it's a pretty good assumption that it will never be acted upon. Next slide. So I just want to, this is a historical slide that I had to dig up from my files. And so this is where we were in 2017. So you can see in 2017, we were already starting to see some significant increase in viral load coverage. Viral load coverage tends to be the number of viral loads done divided by the number of people on ART as a proxy for viral load coverage. So in Kenya, we were at 89%, but in other large programs such as Zambia, we were only at 28%. So that was in 2017. Next slide. This is more recent data, and this data is actually also designed to show what level of resiliency we've been able to achieve with our viral load program in the setting of COVID. And what you can see is that our viral load suppression has actually been quite high for quite some time, and that we've had stability in the 75 to 78% range for viral load coverage, which then I will translate into numbers. Next slide. Sorry, next slide. Thanks. Yeah, so that what you can see here is that that 25% or so of people who are not having viral loads done, at least according to our facility-based data systems, measures to 4.5 million people in the PEPFAR programs that we do not have viral load data on. And we're, as I said, because of the disconnect between facility data systems and LIMS, we do not necessarily think that's a reflection of these viral loads not being done, but just not the results not always making it to the chart. And as you can, but suppression remains quite high. Next slide. And then we've seen a significant increase in our levels of suppression correlated with PEPFAR's other big initiative, in addition to scaling up viral load testing, was to scale up transition from efavirenz-based regimens to dolutegravir-based regimens. And we've actually seen quite a nice correlation between the scale up of TLD transition and the increase in viral suppression that we're seeing among our cases, among our viral loads that we are able to capture. Next slide. But it also is important to recognize that within, I apologize for the bottom of the slides, these are different age groups, so we can't really, I'm not sure you can see the very bottom of the slide, but these are different age groups. So you can see that the younger age groups tend to have lower levels of viral load suppression compared to the older age groups. And so that might target us for some special approaches to viral load monitoring in these groups, and we're definitely looking at that, especially in the youngest age groups and even in the adolescents. Also of note is that dolutegravir access for the younger age groups has been delayed in many countries, but we now have very good access to dolutegravir-based regimens for almost all ages. Next slide. So what do we do with the viral load when it does measure not suppressed? And of course, that's going to depend on the assay. It might be above 1,000, it might be above 50. It just depends on the limits of the detection of the assay. So now with TLD transition, we wanted to make sure that most of these patients were switched to TLD. And then if they are on TLD, because we haven't seen nearly the level of resistance on TLD that we did with efavirenz-based regimens, we are not necessarily jumping to a second-line regimen with an elevated viral load, but instead we are doing what we call enhanced adherence counseling, which varies from country to country, but is an intervention that has been applied in many different settings, and we're trying. And many studies that are out now and are soon to be released do show that with dolutegravir-based regimens, adherence counseling seems to work in terms of patients resuppressing. But at the end, at the bottom, you see that we will consider PI-based regimens if virologic failure. So this is the PEPFAR approach. This is a modification from the WHO approach. Next slide. And these are some of the tools that we use to help with our enhanced adherence counseling, high viral load registers, various tools that you see here that we can certainly discuss if needed. Next slide. Now, we heard from Chris about viral load, the utility of viral load, POC, and I will say that I think the jury is still out on that. And the reason is because it is difficult to tease out what the role is of the POC platform per se. CDC was involved in a study in Nigeria that recently was published where we compared, using Cepheid, we compared POC viral load or near POC viral load monitoring to standard of care in two Nigerian clinics. And first of all, you can see that the numbers are relatively low in terms of enrollment compared to the scale that I just shared with you. But viral suppression, if you look at complete case, that is people who just were able to be followed through for the full 12 months. There was not that much difference in viral suppression. Some differences, though, in the intent to treat analysis. But I think that this sort of doesn't. I don't think this means POC platforms are not going to be useful to us, as much as there are so many other factors with retention and other issues with maintaining people on their antiretroviral therapy that we find the big challenge in the PEPFAR programs, that at this point, it's hard to see. There's no question that the turnaround time is decreased with point of care, but we still remain uncertain about what is the actual benefit on a population level. Next slide. Which certainly suggests that there may be subpopulations that would be better for use for viral load POC. So in other words, to continue, it's going to be hard to do 4 million viral loads using POC. So we have to find ways to do viral load with the existing systems that we have, but then to look at, are there specific subgroups that we might want to consider POC? Children and adolescents, I showed you that their viral suppression is lower, and so getting a quicker answer using the better turnaround time that you get with POC might be an advantage. And then other populations, especially populations that have already demonstrated viral non-suppression, should we be considering viral POC, which does still have a lower throughput than the systems we have in place right now. Next slide. So finally, I dare to dream on this. So I came up with this slide given the topic of the webinar today. In terms of ATI, grand scale up of ATI, including possibly the changing of the acronym for ATI and how that compares to ART. So right now with ART, the intervention that the viral load helps us with is enhanced adherence counseling that I mentioned, and then ART regimen change, as I mentioned, if indicated, possibly at a time where you might reduce timing it, so you might reduce drug resistance. Improved data use at the facility level. We want to continue to improve the data use and transmission reduction interventions, including U = U, and prep for discordant partnerships, with Tim alluded to a little bit in his opening statement. So then in the ATI world, and I'm thinking of big time ATI world, like millions of people undergoing ATI, which is what I dare to dream might happen in the PEPFAR world in the future. Of course, with the intervention, the viral load would determine who needs to have their ART regimen restarted because of failure of the ATI, so to speak. And then, of course, trying to get improve our data use at the facility level, and then transmission reduction of interventions. So in some ways, there's a lot of similarities between where we are now with ART and where we might be in the future with ATI. So one question I have for the panel would be, how important is the timing of the non-viral suppression, given the reality of non-viral suppression that we are presently living with under our ART programs, even in the setting of what we think is the best therapy we've ever had, TLD. Next slide. Thank you.
Okay, excellent. Thank you. Thank you very much. Oh, yep. Sorry, Bonnie, go ahead.
Nope, go right ahead.
Excellent. So these were fantastic talks, I think, to really launch into our next hour of our program, which is going to be a discussion-focused roundtable to really dig deeper into some of these issues and get some type of discussion, consensus, disagreement, or agreement as we move forward. And the first section to talk about accuracy, sensitivity, and other important technical considerations of point-of-care viral load testing. And perhaps also we could bring in a bit about other markers to direct reinitiation of therapy that are not viral as well. I'll invite Dr. Sarah Fidler to moderate our next very important discussion section. We'll have 20 minutes and I will be keeping a time. So I will give about a 2 to 3 minute warning when we are approaching the end of this particular session. Dr. Fidler.
Thank you. And Tim, thank you very much for your nice introduction. And thank you very much to the speakers we've just heard up till now. I have written copious notes from everybody's talk, so forgive me if I've kind of got mistakenly referred to different things. I had understood that the whole focus of what we want to talk about here is how we monitor viral load when we're thinking about cure trials and ATIs. And I just want to clarify, that's my understanding of it. And I don't think we're proposing at this stage in any way that we are going around sort of looking at a global situation where we advocate people to interrupt their therapy. But I think many of us who are working in the field understand the challenges of how best we make a trial. And I think, Tim, you summarized it beautifully at the beginning, but how we make trials actually work for our individual participants in the first place, not to focus really on the broader populations. And I think we heard from Siobhan's talk about how they've managed this in the context of a prevention trial, about what treatments, when treatments don't do as we anticipate and what tests best work. And I just to sort of set the scene, and then I would really like to open it up for questions. But I think part of, if we go to the trials first, we have to think about what the trials are trying to look at. And many of the research studies that we're all conducting are looking at alternative therapeutic approaches towards controlling viral replication below a threshold which is going to confer any risk of onward viral transmission, and also, of course, any risk of individual participant sort of progression of their HIV disease or immune dysfunction. So I think whilst it's incredibly encouraging that there are all sorts of different discussions, we really want to be able to make sure that we can pick up with the assays we've got a threshold below which we can feel confident that our participants are not going to be putting their partners at risk. And I think my overall summary of the technology we have available to us right now is that most of the what are called point of care, or I like that concept of near point of care technologies, are still not quite sensitive enough for us to feel confident. And that's why we're a bit stuck at the moment with laboratory-based testing. And then in terms of the practical issues about how to design these trials, I mean, I think, Tim, again, you summarized very nicely about not only the sort of practical issues about coming in, having a viral load test, submitting it to a local or district laboratory to run these assays, but the time lag between the sample to that participant getting the results and then acting upon that. And it was really fascinating seeing those data that Lydia presented to us about the immunological biomarkers, because at the moment we're very passively waiting for a viral load test result to be able to say, oh, look, last week it was undetectable, but now it's not. And I think that's very challenging, both emotionally for our participants, but also on a practical logistics. So just to finish off, and I don't know if maybe Roger has put it in the chat, but there was actually a Cochrane review of point of care viral load testing published earlier this year that looked at 14 studies, 20 evaluations of about 8,500 participants, comparing the molecular, what they call point of care tests for diagnosing viral load levels, to say, you know, how do they work in terms of sensitivity and specificity? And they're all pretty good in terms of sensitivity and high specificity, but the threshold of detection is about 1,000 copies. And so that's really not what many of our trials are actually looking for, ideally. So I'd like to just, having made those initial comments, just open up now to questions from anybody on the call, first of all, to any of our speakers, or to just join this debate. So I've just seen in the chat that Chris has said that the Kefade cartridge is 40 copies. So that is the only one, as far as I'm aware, Chris, that is actually to a level that we'd be comfortable with in a clinical trial. I don't know if you want to talk a little bit more about how you could anticipate that being useful for an individual participant, because I imagine it would still require at the moment that machine to be held in a clinic or a community setting. So unless we gave those actual machines to each of our participants to take home, it still requires them to come into a service to get that result.
Yeah, it would. It would require some sort of power, right? Either you go to them with some sort of mobile van, or and organize it within the community, or there's no way to take these types of things home at the moment.
But Chris, if they were costed into a trial, for example, so that each individual participant, because bearing in mind a lot of these trials are relatively small patient numbers, is that a feasible option?
I think it depends on the size of the trial, how many patients you're considering, and how often do you want to do the testing, and then what type of testing do you want to do. Obviously, we're 40 copies per ml, but it's also using plasma, right? So
they've got to have a venous blood draw. It's not going to. Okay, fine. I'm just checking on the text. Sorry,
we've just designed we're using the Gene Expert in one of our ATI studies, or we're just about to start. But the main issue is the centrifuging still, isn't it? If you bring that assay into the community, it's not really the testing. I would say, you could probably use the battery packs, or can you connect it to solar panels? I don't know, but the key issue is the centrifuge, isn't it? Yeah. Sarah, you've done some microfuge studies, I think, to try to work on that problem. But I think, Chris, you haven't found a solution yet.
No, we haven't. No, that's right. I mean, ultimately, it'd be nice to work off something like a finger stick, but the problem is, the sensitivity. You're probably going to be up in that 800 to 1,000 range, which is not going to have good enough performance.
Chris, do you want to just explain to maybe people who are not quite familiar with your assay why sensitivity goes down like that on a finger prick?
Well, it's really the volume, right? Because you're going to be working off probably 50 microliters. And you've also got the issue of, intracellular virus as well, right? So, when you lyse the red cells, you're going to get all of that, added as well. So you're going to lose performance. It's fine. It seems to be fine at 1,000 and above, but once you get below 1,000, then it starts to become challenging. HCV is an exception because, we have, the sensitivity of our test for HCV, I think, is around 25 copies, and yet with finger stick, it's around 200. But it just doesn't translate across to HIV, unfortunately.
And Sarah, I'm just checking with Chris, the integrated DNA was also an issue, wasn't it? Because you've got a whole blood sample.
Yeah,
that's right.
That seems to be the other issue, isn't it? You've got this interference of virus sequences. Is that right?
Yep, that's right. Because the separation step tends to lyse the red cells, right? So you get release of all that intracellular DNA.
So I guess one question I would have for the cure researchers would be, is the integrated DNA an issue in these ATI studies, given the cure strategy interventions that might be looked into being evaluated by ATI? Obviously, it is, misclassification. It causes misclassification for people on ART, and so we've paid a lot of attention to it. But does the same level of attention need to be paid to it for this scenario?
So Elliot, if I can start answering that question, but I'm certainly not an expert virologist on this, just to have that caveat. So the problem is for us is that if we definitely could be able to determine what was integrated DNA and what was replicating RNA, then you're right, in terms of our outcomes for our trials, it would be fine if we could define which is which. But as far as I'm aware, we can't do that. So all it does is contribute to a primer that sticks onto a bit of DNA and says, yes, there's HIV here, and we can't tell which is which. And so it looks to us like there's virus at higher level. And if we're trying to help our participants monitor their viral load with respect to decisions for, sexual practices and also for the primary endpoint of studies where we want to restart ART, it has, from my experience anyway, it's confused the issue. But I don't know if the technology's got better, because we did that study a couple of years ago now. So maybe I'm behind the times here.
Maybe I can also add in on that as well. A lot of the strategies that we're thinking of implementing, MAPs or ATIs, hopefully will reduce the burden of circulating cellular HIV nucleic acids, DNA, RNA production as well. But this is not a direct given, and especially if you're thinking about immune therapy approaches, therapeutic vaccinations, or going back to the PrEP monitoring and things like that. This certainly does become an issue if you're going to be detecting kind of cellular DNA. A lot of these probes, I presume, Chris, are targeted towards fairly conserved areas of the HIV genome, which will pick up even non-intact HIV DNA or genomic DNA as well. And so it's going to be a little bit confusing, I think, when you do have that, especially if we're thinking about less than 40, very low level detection where you might be able to you're picking up on some of the cellular DNA. That said, if you have a level at the time of ATI, if you know before you stop therapy that this is kind of your baseline, right? That compared to a highly sensitive quantitative PCR, that you have this baseline level of nucleic acid detection within a sample, then perhaps that could be useful going forward if you're not able to, if you don't see a change, if you have, say a low level of 20 or 30 copies or 50 copies, 100 copies. But it's the change from that baseline at the time of ATI that may be more important in the setting that if you do see an increase in that level, either it indicates that you now have free plasma RNA, or virion particles that are circulating, or you have actually an increase in expansion of cells that are infected with HIV, which would also be not ideal, because that would obviously probably lead towards more RNA production, transcriptional translational activity, and virion production. So I think there is a potential use if you know what the baseline is compared to PCR before you stop therapy, but this is certainly an ongoing technical issue when using these whole blood products.
Can I now move to ask us to think about some of the really interesting data that Lydia particularly presented about, many of us running these trials, it would be fantastic to be able to do a blood test and say, it looks like your parameters suggest that the next time you measure viral load, it's going to come back. Because many of us have participants, like you say, Tim, people who've been in trial for maybe up to a year of therapy, we're driving them nuts by coming back every other week, having a viral load, and we have no way of being able to reassure them that just because last week's viral load was undetectable, it's going to continue like that. And I was really quite interested in your cytokine data and the sort of markers of activation from the innate immune system. And there is, of course, a point of care CRP test, for example. And I just wondered, Lydia, if you thought that might be something that we could sort of explore at this stage in our studies. I mean, I spend a lot of time looking at CD4, CD8 ratios in people who are, still virally suppressed, but looking at if they've changed and haven't come up with any magic cure, sort of algorithm yet. But be interested in thoughts.
I don't know if Lydia's on, who can.
Oh, okay, it's Lydia not here.
A beautiful presentation and kind of overview of that data. But having been involved in some of this work as well, that the more we do these hyper-intensive early ATI monitorings, the more we see that's happening behind the scenes. And this is almost certainly due to tissue smoldering, whether it's true replication or viral production that is not able to immediately set off the exponential cascade. So, for example, the R0 values may still be less than 1 in the local tissues, given the fact that there could be immune responses or just lack of target cells at that certain period of time. So you could have these kind of chances. But there's certainly something that's kind of going on behind the scenes in the deeper tissues. Obviously, we can't sample tissues directly, routinely in ATI studies in larger scales and in resource-limited areas. But it really does suggest that there may be markers that will predictably come up at the time that this kind of virus is smoldering in tissues, but before it has a chance to have this exponential breakout and detectable in the peripheral viral load blood. And I think that, and so certainly there could be, but I also think that there are other things that could, oh, Lydia's back, oh, fantastic, who can weigh in, but there are probably other non-specific processes that could cause these to go up as well. So it brings up a whole sensitivity and specificity. But I'm going to hand it over at this time.
Well, I think, thank you, Tim. I think you said it all. I don't think we have enough measurements to really define a marker that we can use, but I certainly think that there are things happening before even the viral load is detectable. And what happens in tissue can be found in the blood if we look at enough people and if we find the right measurement. So I agree that it might be a complementary tool, but eventually you still need to do frequent monitoring in those people. But I don't think people have looked enough. And again, these ATI are small numbers, so it's hard to find those markers. And perhaps we should think of going back to some of those samples and doing these type of studies to define those markers.
Lydia, can I just ask you, following up from that, do you think it's interesting to me that you didn't see a sort of CD8 activation? Because I would imagine that the CD8s would be activated prior to virus coming back as they start to see antigen.
Sorry, I'm playing with my screens. Yeah, we were hoping to see CD8 activation prior to viral rebound. I don't think, well, for sure we don't see it. We see innate cells recirculating from the tissues early, but definitely not CD8 T cell activation. And even in people that are rebounding, who are rebounding fast, we see that activation is even delayed after viral rebound. So CD8, CD4 to CD8 ratio, CD8 T cells is really not, I wouldn't go there for early markers. But again, going back to innate responses, perhaps B cell responses and those TNF receptors and things that have been seen also after vaccination, like yellow fever or those things, might be earlier markers than T cell activation, for sure. And we've measured that extensively with proliferation marker, activation markers, tetramers, and global T cells. We've not seen any early. Perhaps the T cells are activated in tissues and not recirculating at that point.
Yeah.
But in the blood, that's pretty much for sure. We don't see anything before.
Really interesting.
And just
to blunting.
Maybe,
sorry. Yes.
Maybe I can just add to that. This is Tumbi, just to support that and say, in our, the fresh acute infection cohort, in this very early treated individuals that we started treatment before peak viremia, we see a lot of myeloid cell activation, but not T cell activation in the ones that we catch before peak viremia. So sometimes you completely abrogate T cell activation, both CD8 and CD4 T cell activation, but you still get a lot of myeloid cell activation, monocytes, and even plasmacytoid dendritic cells. That seems to be prolonged.
Tumbi, just before we end the session and while we have you talking, I think one of the really important aspects of our discussions here is how we extend the cure research we're doing. And I know you're doing some already, so I wasn't suggesting for a moment you don't know how to do this, but do you want to share with us your experience of doing ATIs in your setting compared to a setting where there's a few more resources, and have you been able to adapt to that in terms of your viral load monitoring? Or do you do the same kind of weekly venous blood sampling?
Yeah, so yeah, we at the moment we are actually doing ATIs, but it's actually we are doing it every 3 days or so. But again, this is done in a centralized, facility. So perhaps it doesn't quite reflect what we might want to eventually get to, which is how do you actually roll out this to the general population? Obviously, we are not there yet because our studies are sort of clinical studies who are in a well-controlled sort of clinical environment. But the same questions that have been raised, that were raised before by a lot of the speakers here today, are obviously at the top of our minds with regard to safety. How do you make sure that we protect both the safety of the participants, but also their partners? And this is, of course, very difficult. And so what you have had to do is to essentially, require that, we have, at the moment we are doing bi-weekly testing. So we are very early in our studies, so we haven't really seen any rebound so far, but this is obviously a big challenge about how to do this and do it safely.
I apologize to be a downer to have to move on to the next session at this point, so we're running a little bit over time. Thank you, Dr. Fiedler. That was a great discussion, and I think it really suggests that we need to be working on these diagnostic tests in the POC and really need to engage industry, which is where there's support, financial and technical ability and capability to really integrate these. And I also want to just appreciate Linda D's comment as well about, for now, until we have these, to really make sure that we keep on with consistent and persistent monitoring as we go on. So with that, I will pass over to Bonnie.
Okay, thank you, Tim. And actually, if it's okay, I had a few of these questions embedded in the section that I was going to lead, and I think some of the questions that are coming through in the chat are really important. So, so I think we might come back and hit on some of these. And yes, in this session, we would like to talk a little bit about how we engage the diagnostic industry in developing the point of care testing and in terms of assay validation and sensitivity. What are the issues? But if I can, I do want to go back to what was just said about frequency. And Thumbi, thank you for sharing what is currently being done in your studies. But I did want to ask the group in general, before we kind of really dive into the industry section, at what frequency should we be testing during the ATI setting? And, how do folks feel about that? Linda, I don't know if you'd like to jump in and comment, but I would love to hear, is twice a week sufficient? Is once a week? Does it, depend on, sort of maybe what the intervention is? Any thoughts on this?
What we do now in the trials that I'm familiar with at UCSF is twice a week, then once a week, then maybe monthly. I'm really not sure that you all have the same assays that we do. I'm sorry that I don't know the answer to that. But I'm not familiar with all of the, how far away are your patients from sites with centrifuges and all that sort of stuff, all the logistical stuff that's extremely important. But I would say once a week. I know that's hateful for participants, but it's more hateful if we do them harm, if we promote unintentional transmission, and then the integrity of the trial is always important as well. So I would say at least once a week until we know we can identify, viral load.
Okay. Oh, great. Thanks. And I can see Liddy has her hand up. So Liddy, you have a question?
Yes, thank you. So I actually had a slide that I didn't put in the talk from Jintanat, who had calculated. So in her trials, the viral load monitoring was every 3 days. And she made some calculation according to the time to reach the criteria for resumption of ATI, which was 1,000 copies, which I think now in the trials, you go a lot longer. So that also would be a requirement that is a little bit more flexible. And so in her calculation, monitoring the viral load every week, once every week, would only have a delay of 1 day of detecting someone with viral rebound, and doing one every 2 weeks would have a 1 week delay. So I agree with testing frequently for the safety of the participant, but I think testing once a week is lower of a burden for the participant and doesn't really delay the ART reinitiation time, especially now that the criteria are a little bit longer.
And Letty, can you remind us again, what was the detection limit of the assay that was used? The sort of the threshold, was it 1,000 copies or was it 50
so
copies?
The viral load was 20 copies detectable, but the resumption criteria was 2 consecutive viral load over 1,000 copies.
Okay. Because I think
which was very restrictive. So I think now people want to go a little bit longer. So yeah.
Yeah, and certainly I think that that's also a really important area of probably discussion and consideration is really what is the necessary detection of the limits, the sensitivity of the assay, and knowing that we're starting to see in some cured trials that you can get viral recrudescence followed by some level of immune control. So what should we be thinking in terms of the tolerability of viral load that is sort of low viremia, and the number of those endpoints that are in that range before we restart therapy. I don't know if there's anyone else that would like to comment on that. If so, feel free to jump in. If not, we can move on from this topic.
This is Randy Tressler, and I work at JADES. I'm the medical officer for many of the treatment interruption studies within the ACTG. The ACTG uses a criteria across most of its studies of 4 viral loads over 1,000 copies per mil for 4 weeks with no reduction from the last week by greater than 0.2 logs. And they do frequent testing up front, and then after the period of time where we see a lot of the viral rebound that was shown in the slides earlier. So for 8 weeks we do weekly viral load testing, and then after that we do every other week viral load testing out to 24 weeks. And after that period of time, we can actually consider going to a wider range. As soon as we have a detectable viral load, we revert back to weekly testing so that we can get as close an estimate as possible to the ART restart criteria. And I apologize, but I have to go to another meeting.
Okay. No, thank you. Okay. Very good. Any other thoughts on that topic, or we can move on to the next topic?
Hi, this is Elliot. I just have one question maybe for Linda. So Linda, given that the frequency and even these other discussions we're having could be barriers to rolling out these studies in resource limited settings, are there compromises that we can at all consider, given that without those compromises, you're actually blocking these people from even access to these studies?
I mean, I'm from the school of they maybe should be blocked from the studies if you're going to hurt them, if people are going to get infected, and the whole study is going to be a waste of time. What you may consider, and I'm not sure what, what's considered unethical as far as reimbursement for patients. I mean, it may be that they'd be willing to come once a week, come in once a week for blood draws, if they were compensated enough to make it possible for them to do so.
Okay. All right. Thank you.
Feels like a compromise to me.
Linda, I agree with that. And I think that, the people who are extraordinary, who take part in our, cure research, absolutely, they're giving up enormous amounts of their time for this. And I think we very much always try to ensure that their reimbursement reflects that. I don't think, in my mind, there's no debate about that. It's really how we can do it better.
Yeah, there's such low rates in the United States, really, when you think about what people go through. But, then there's the ethical considerations, and the ethicists are always afraid that, we're going to be enticing them to do something that may harm them. But I'm not sure about your rates in low and middle income countries. And what your ethicists say there, so. It might be, I know it would help people that I know in the United States who give of themselves and aren't working and that sort of thing, who are available for these trials, that maybe make it easier for them to get in there more frequently.
Okay, so I want to jump over to the topic about you really focusing on what we think are some of the issues in terms of implementing point of care viral load testing. Maybe just I think, Elliot, you sort of teed this up a little bit about speaking about the benefit, and maybe there's differences with different population levels. Maybe it depends on whether we're talking about the preventive treatment care or cure arena. But so Elliot and perhaps Chris, from your perspective, could you, sort of highlight what you see as the current issues and what we need to overcome in order to, really accelerate this and make these point of care tests more available?
Well, I mean, I can just tell you the studying this to prove the benefit is really, really hard from our experience in the Nigeria study. And I'm not sure, and I'd like to think that, if you have patients who are more likely to fail, such as those, recurrent, I would like to think the study would be easier to design, but it would still be very difficult to design. And obviously retention in the study would be more difficult too. So, I don't know, but I definitely think that, and I mentioned this even in the mobile case, I think that, if you have an ATI subject in this community and an ATI subject in that community, it's going to be hard to justify the mobile. But if you have other high risk patients in that community that you're using these technology for also, in addition to the ATI subjects, for example, then it might be a little easier to do that. And so I think you're just going to have to identify who would be, there's no question we love these, shorter turnaround times. But I guess the other thing I failed to mention in my talk is that when you have 95% suppression or greater with TLD, in Botswana, it's like 98%, then, you're talking about a lot of work to identify a few people who are failing. So in the case of Botswana, it's 100 viral loads to identify the 2 people are failing. And for those 2 people, it's important to identify them. Don't get me wrong. But, I think we have to think about that in terms of our efforts. But I think finding uses and then putting the ATI question within those uses, I think, to me, would be the best way.
Mm-hmm. Thank you. Chris, did you want to comment?
No, I would agree.
All right. So I did have another question, again, directed a little bit at Chris and Elliot, but open to anyone on, any of the presenters or anyone participating today. Just thinking about other emerging technologies in nucleic acid amplification or detection, or even the digital space. So, what do we see as some of the advances in terms of the next generation point of care test? And just kind of calling out the detection approaches that people are exploring around CRISPR, maybe isothermal. If you can comment on where the opportunities may be around some of those emerging capabilities. And then is there more that we can do sort of in the digital space as well? for providing rapid results?
Yeah, good question. We're obviously starting to do some, the TB fingerstick assay is basically a biomarker panel that will enable differentiation from active and latent TB. And we have other biomarker panels that we're looking at for specific indications. But yeah, I mean, there are new technologies coming along. But, I haven't seen sensitivity and specificity performance data on, they all sound great, but, and we need practical hard data to be able to assess, how good they're actually going to be.
Anyone else want to comment?
Chris, do you want to maybe answer what Roger was saying about regulatory? Because I know for the Cepheid, you had some, a few challenges with your WHO pre-qualification, for example.
With the which application?
Was it for the Cepheid platform? It was a process to get the WHO pre-qualification, right?
Yeah. I mean, yeah. It's an essential requirement, obviously, for PEPFAR and for many countries. And it's a process. It's not something that gets done quickly. It can take anywhere from 6 to 12 months, depending on where you go and what samples are available, etc. So, there's not only challenges from that getting the WHO PQ. Then, from a country perspective, there's also challenges, right? Because we pretty much have to do, some sort of validation or verification in every single country before they will use it. So, you have that increased hurdle on top of it, right? And then that can last anywhere from basically 1 or 2 months to 6 months. So, all of these just build one on top of the other. So it is a process.
Mm-hmm. Okay, so maybe last question for this session then would be, are there important partnerships that we need to form to be able to accelerate this effort? So just thinking through some of the challenges and the issues. And maybe Chris or Elliot.
Sorry, what was the question? I was reading the question that was in the chat from Roger.
Just if there are other important partnerships that maybe we need to form to accelerate this process. So partnerships between the diagnostic industry, community, other industries, other technologies, researchers, clinicians. Any thoughts on that and how we could accelerate this through partnership?
Well, for me, specifically speaking of Africa, I would think the Africa CDC and ASLM would be the two that I would think of, especially because, even if you get the hurdle of, even if you cross the hurdle of even getting the country level regulation process done, as Chris was talking about, you still then have to decide where is it going to fit into the strategic use of diagnostics in the country. So, for example, in South Africa, where they've really done they feel that they've done a very good job of rolling out plasma-based central lab or semi-central lab, technology. They still talk about pockets in the country where point-of-care viral load would be useful. So I think getting some sort of strategic approach to how these technologies get placed is something, and certainly Africa CDC and ASLM can help with that, I think.
Well, I think, Elliot, to that point, there's been, as I said in my talk, every PEPFAR-funded country has undergone a diagnostic network optimization, and they've looked at, obviously, their facilities right across the country, and that's for TB, HIV, and looking to see where they can obviously improve access for people. So, it is an ongoing activity. There has been specific activities, diagnostic companies working with pharma companies in, areas such as hepatitis. But there hasn't been so much in the area of HIV. And there are some partnerships going on in HPV, but again, I'm not familiar with many in the HIV space, really.
Excellent. I think we are a little bit past time. So thank you, Bonnie, for moderating the session. And would like to next ask Dr. Thumbi Nungu to talk a little bit about monitoring viral load in lower and middle income settings, planning for access when there is a cure, potentially, although baby steps currently. And maybe we can kind of continue the discussion on how we can really implement, design, approve many of these new technologies worldwide.
Thanks, Tim. I think that when I was thinking about this topic, maybe we should first address the issue of viral load monitoring for research purposes and see and talk about where the need actually is in a research setting rather than in the general population, because I think the approaches to the two will be quite different. And maybe just as an opening remark, it seems to me that for most research purposes, I think that monitoring viral load in a centralized laboratory probably makes sense for most settings, because most research settings will have the capability and the infrastructure to be able to do that. There might be instances where centralized laboratory testing may not be practical, or where you may not want to do it if you want to have a wider net of study participants. I'm talking very specifically about research setting here. So I guess what I wanted to hear from people first and foremost is, and we have talked quite a bit about having point of care testing and how that would improve research and care, because it would help to make sure that the results are generated quickly, and also so that monitoring can happen quickly for people who are in research studies, and allow the researchers to respond quickly. And so we have talked about a point of care testing, and I think everybody would agree that that is necessary. But what I haven't heard much about today yet is home-based testing, and whether people think that this is necessary, particularly for these kinds of cure studies where there's going to be treatment interruption and the need for people sometimes in resource-limited settings, people move to other areas or are away for a while. And there is a need, if somebody, for example, is in an analytical treatment interruption kind of study, for them to do some kind of viral load monitoring that would allow them to quickly respond, for example, if viral load goes up. So I just wanted to hear, I don't know whether there are any, and maybe colleagues who are in industry can maybe talk about this. I don't know whether there are any home-based sort of viral load testing assays that are in development or are being thought of, or even whether people think that that is necessary, particularly if you're going to expand the HIV cure agenda to resource-limited settings.
Yeah. So then maybe I can start, and then colleagues on the call can also add their experiences. So we are currently doing a study right now through the HIV Collaboratory, where we are leveraging a Tasso device, which is a little device that you put on your arm or skin, or some locate on your leg. And essentially, in a very painless way, it will collect blood sample. So we're doing that in a cure ATI setting with in-home blood collection. It is not in-home viral load testing, but we're collecting several of these sample endpoints, time points throughout the week in between clinical visits, as well as collecting samples at the clinical site as well. And we will make viral load measurements from those off of those devices and compare to the venous puncture blood collection, viral load measures that were collected at the clinical site. The hope here is that you could use a device like this in an in-home setting, essentially, to do the blood collection. And then, the challenge here, though, it's, for a lower middle income country, is that we are using the mail system then to actually get that device to the site where the analytics are going to be performed. So certainly it's very early in these days, but the patient and the user experience has been very positive. The community feedback has been very positive so far. And, we'll look at the complete analytical data at the end and really pressure test the feasibility of doing this. But I think it's headed in the right direction, sort of as a very early generation concept.
Bonnie, does it give you viral load measurements in real time, or how does it work? Or is it just a sample for a device for sample collection?
It's a device for sample collection. It is mailed the same day, so the sample is received the next day at the clinical site. So theoretically, if it would not be same day results, but the results would then be the duration before you receive the results would depend on how quickly the clinical site could provide that data. Theoretically, maybe a 24, 48-hour turnaround time, if everything moved at a swift pace.
Is there any other sort of device for home-based? Is there any need for home-based care sort of testing? Would that kind of facilitate increase the number of people that participate in these kinds of studies?
So again, I'll just jump in. I imagine that to be the case with our very limited sample size that we have right now in our cohort. But what we learned is, we actually made this study as a sub-study to the parent ATI study. And what we found is that people were actually enrolling in the parent study because they wanted to be in the sub-study, the in-home blood collection viral load test. So it was actually driving some, our participants to actually enroll in the parent study because they were so eager to see if this in-home blood collection approach would simplify being involved in cure trials.
Okay. And then I just thought that we should also probably mention viral load monitoring for for pediatric setting. So I don't know whether there's anybody who is working in a pediatric setting, particularly for cure research, and what the experience has been with the point of care devices for viral load testing. Anybody wants to jump in?
Hi, Tommy. This is Roger. We are.
Hi, Roger.
Yeah, we are doing that with children. I guess my comment would be, in terms of the diagnostic aspect of this, we are concerned that the presence of dolutegravir in various settings, whether it's maternal dolutegravir, when we're making a birth diagnosis, or other dolutegravir based usage is really keeping viral loads very low and affecting our and really affecting the threshold. Just a quick comment on the other, since I'm speaking, I wanted to say about our rebounds in based on the last part of the call. What we're seeing is these kids rebound very quickly. So when we did a BNAB study, we expected a number of kids to rebound. We saw kids rebound very, very quickly. And we did, we were using TACMAN in that setting, although we are using Cepheid in other settings. but even the duration of even with 1 week testing, intervals, viral loads were reaching 4 to 5 logs before we could get ART back restarted, even if that restart occurred within 7 days of the initial detection of rebound.
So, Roger, what have you done with regard to the low viral load challenge? Like how are you dealing with that problem? Because it seems like a real challenge, and Dr. Delani also mentioned in the beginning in terms of people who are taking PrEP having very low viral loads. So
it's very similar. I mean, as the PrEP situation. I mean, if we're talking about diagnostics at birth, what we're doing is basically acknowledging that we may miss some of the we're using Cepheid at point of care or near point of care at birth, and we're acknowledging that we may miss some. So we're being very, very rigorous about making sure that a follow-up test is done at 6 weeks to be sure we would capture anybody. But even then, a lot of these kids are high risk and are on 3 drugs and as postnatal prophylaxis. So there's still a concern that the 6-week test could be false negative. So we're going to probably need testing beyond that level as well.
Okay, maybe just because we are almost running out of time, I want to move quickly to planning for access when there is a cure. And I know that we are very far away from having an HIV cure, but I think this is a good discussion to have in terms of what, if we were to ever get a cure or a strategy that works for long-term remission, what would actually be needed to roll out such? Because at the moment, we are talking about all these challenges, and I'm just wondering whether this doesn't make it, viral load monitoring actually wouldn't be one of the biggest challenges unless the situation changes because of the limitations that we have with the current system, where the point of care testing is there's very limited options for point of care testing, and so somebody who has been thinking about this can also comment on this issue.
Well, I would just say that, I think, as I said earlier, I feel like we're in a pretty good place with TLD. And so it's almost like the cure would, from a standpoint of viral load monitoring, the cure would have to be almost comparable to TLD in terms of how much viral load monitoring we need to do. So we have a long way to go. So this discussion of weekly or even biweekly or even monthly viral load testing is, of course, it's important for research, no question about that. But in terms of what you were talking about and what I like to dream about, I do think that that it needs to be somewhat comparable to what we have now, where 5-10% of people every year fail their therapy, and maybe it's just adherence, maybe it's true failure with resistance. We'll see with TLD over time. But to me, I think that's ideally what rollout would look like.
Thanks very much, Elliot. I think I will hand it over back to Bonnie because of time limitations, so that she can wind up. But this is an important topic, and I would like to thank everyone for participating. I don't think we had enough time to really interrogate all the issues, but this is very, very good opening for this discussion to help us move forward. Bonnie, over to you.
Thumbi, thank you. So maybe I'll just make a few remarks, and then I'm also going to have Tim sort of chime in here with some summary remarks, and then we can close out. So yeah, I think in general, we had great discussion around the importance of point of care testing and in the cure setting, and that it is certainly becoming more important to consider how we would actually implement this and how do we roll this out in the various settings, especially beyond centralized lab testing, considerations around different patient populations, the timing and certainly the safety to the patients are really important. And then in terms of the assay itself, and the implementation is, how do we do this intense monitoring? What sort of analytical sensitivity, what sort of frequency is going to be needed? And then what, on what platforms, what sort of technologies will be used? So those are some of my high level takeaways, and a lot of good discussion and comments in the chat as well. But Tim, I'm going to turn it over to you as well for some closing remarks.
Sure. Thank you, Bonnie, and thank you, everybody, all the speakers and panelists. I think this was very engaging. I could talk for hours about ATIs and how to do modifier, right? I think a lot of us could spend a long time really thinking more deeply about these issues, and a lot of us have also been engaged with ATI studies and thinking about these for many years. But I have to say that this was a bit different for me. I know that we had somewhat limited time and whatnot, but I feel like we're actually making progress in that, looking at some of the Cephia examples that Chris was presenting, but also the fact that we are getting better at some of these viral load technologies, point of care technologies. We're learning more about potential non-viral biomarkers that might rise up very early or kind of predispose or pre-think about this, that those could be potential targets as well for either POC or at least kind of rapid turnaround testing. I think that there's more engagement now, not just in kind of resource-rich areas, but in middle and lower-income countries are now starting to really, kind of as we implement a lot of these QR studies across, the global platform, not just based at a few centers here and there that have a lot of resources. And I think that we're starting to see that these studies are doable, that they're relatively safe if they're done well. And that I think that we will have technological advances. Obviously, we think about the volume of blood. As Theranos has taught us, you can't overpromise on very little, that you actually need sample to have sensitivity, to have accuracy, to have specificity and precision. But I think I'm overall kind of, at least personally, I feel that we have a little bit better grasp of how to do these types of studies. Clearly, we need to kind of discuss more about the ethical concerns, the safety concerns to partners, and to the individual stress. And I also want to stress that we should not leave out the participant experience in testing. Even if we say, once a week or so is sufficient, we have to remember that every time someone has a test drawn, there can be a huge amount of anxiety that drives in participants, and that even a couple of day wait can really take a toll over a long period of time. And so this is not just a technical issue. This is really how we interact and interface with our participants, who are really the ones who are volunteering not only their own livelihood essentially to these studies, but have volunteered to undergo with potential risks and certain anxiety in a lot of these studies. So I just want to thank everybody for kind of contributing this contribution, and hopefully we can really kind of use this as a springboard to really engage industry, to say, look, we're making progress. We have better technology. The COVID pandemic has completely changed right since the beginning. The Gene Expert, we were all using that for SARS-CoV-2 testing early on. Point of care testing for antigen tests has completely changed how we diagnose, treat, manage, and think about, and even worry about SARS-CoV-2 infection. And I think, dramatic impact. Obviously, we can't just do a nasal swab for HIV viral load. I get it. But the fact that these things are coming online and that we're seeing that they can actually have a profound impact on the way that these studies, I think is very important. And we should use this as momentum and to nudge our corporate sponsors that this is actually incredibly important to have these types of POCs, even if they're not immediately going to lead to dramatic financial gain, that over the long term, these will actually supplant regular viral load testing and routine clinical care as well. So what we do for ATI studies will clearly have a large expansion way beyond that and be worthwhile for the corporate interest. And so I will leave with those comments, and just wanted to thank everybody for coming in and to really participating in this lively discussion.
Okay. All right.
Thank you.
Thank you, Tim. So really quickly, as mentioned in the beginning of the session, the guest presentations have been recorded. The recordings will be available by our IAS staff in the coming weeks. A report will be shared with the participants as well. And we do hope to see you all at the next workshop, which will take place on October 19th, and it's focused on non-invasive measurements of HIV reservoirs. So thanks everyone for joining. Thank you to our presenters and those who led the panel discussions. We really appreciate your input today. So have a great rest of your day. Thank you.